Assalamu alaikum, everyone. My name is Jamshed. I'm one of the consultant medical oncologists working at Shaukat Khanum Cancer Hospital, Peshawar. So thank you for joining breast cancer session 2. And I welcome you all again on behalf of Shaukat Khanum Cancer Symposium Committee. In this session, we will discuss breast radiotherapy as well as metastatic breast cancer. And we will have presentation first, and then question and answer session will be conducted at the end of the session. This session will be chaired by Professor Abbas Kokar, and the co-chair will be Dr. Taullah. So please, can you join her here? So now I would like to introduce Dr. Abdullah Al Hasso. He's consultant clinical oncologist working at Beatson Cancer Center, west of Scotland, Glasgow, UK. He would be discussing about current evidence and future direction in breast radiotherapy. Thank you.
Hello and good afternoon to you all. Assalamu alaikum wa rahmatullahi wa barakatuh. I am Abdullah Al Hasso. I'm a consultant clinical oncologist at the Beatson West of Scotland Cancer Centre in Glasgow. It's an honor and pleasure to join you in your conference, and I would like to thank the organizing committee for their kind invitation. My task today is to give an overview about the current evidence and future directions in breast radiotherapy. As you know, radiation treatment in breast cancer is quite an essential component in the overall management plan, and that there has been certainly over the last 20 years or so major advances in the diagnostic aspect as well as in the management of breast cancer, including systemic treatment, surgical treatment, and this has clearly improved on our breast cancer outcomes and significantly improved our understanding of the cancer and its biology. And therefore, as a radiation oncologist, we need to adapt, modify, and progress the radiotherapy treatment strategies as well. And that meant radiation treatment in breast cancer is one of the most dynamic research fields and certainly rapidly changing. And certainly in the last 10 years or 15 years, there has been significant change in clinical practice around the world. So if we start the journey of breast radiotherapy or the story of breast radiotherapy, starting with the fractionation aspect of it, in the late 70s and early 1980s, there were lots of studies, as you can see from this list here, to try and establish the role of radiation treatment and breast conserving surgery as an alternative strategy to mastectomy. And the message from this slide is that there is a wide range and wide spectrum of fractionation used. And clearly there was no evidence-based practice and no guidance to standardize treatment. And there was therefore a need to start building that evidence. And that practically started by a number of trials around the mid-80s, when the first trial, START pilot, in 1986, started the fractionation studies, and then we have the START A and the important START B trial, comparing the 50 grade 25, which was the most commonly used, versus the other commonly used is the 40 grain 15. There has been then subsequently, since then, the timeline shows that there are a number of important studies that I will touch on in the subsequent slides. But when we look at the initial, the first fractionation trials, we can see that there is really no difference in, or no advantage in sticking to the conventional fractionation, and that modest hypofractionation is entirely safe, appropriate, and applicable to practically all subgroup of patients. And that is the reason why the 40 grain 15 fraction became the standard of care, certainly in the UK. However, the message also from these studies is that this is certainly not the limit of hypofractionation, and there is a lot more that we can do to progress matters further. And that was the the initial the concept developed into another trial called the FAST trial, looking again at the radiobiology in the context of breast cancer. So it recruited around 900 patients, relatively low risk, T1, T2, and randomized them to the control arm. At that time, the standard of care was 1525, but two test arms, 30 and 28.5 gray in 5 fractions. But the important thing I'd like to highlight to you is that the overall treatment time for all the 3 arms is the same, which is 5 weeks, because in the test arm, it was given on a once-a-week basis. The trial over 10 years' time showed that it is safe, it's practical, it is doable to consider that level of hypofractionation. And indeed, the 28.5 has been shown to be very close to the 1525, whereas the 30 gray arm was slightly more hot. And it also gave us the indication that, well, it will be reasonable to progress the fractionation question a little bit further and combining it with some degree of acceleration as well. So that was then translated into real life, into the FAST forward trial, which is looking at a 5 fractions schedule, but over 5 consecutive days rather than 5 weeks. And also the other important aspect of this trial is that it used the control arm 40 gray in 15 fractions, which is the new standard of care around 2013, 2014. And it also included a slightly higher risk population than what was in the FAST trial. This study was one of the fastest recruiting trials. It recruited over 4,000 patients in a record time. And in fact, it was clearly of interest, of significant interest to patients as well as to clinicians and researchers. The study was done at the right time. And indeed, the results came in very handy around early 2020, when it was first published, at that time, the beginning of the COVID outbreak. And the main message, and the most important message, is that the 2 test arms are non-inferior to the control arm, and that in particular the 26 gray in 5 has shown that it is more equivalent or closer to the control arm than the 27 gray, which was again a little bit more hot. And it was therefore entirely reasonable to consider the 26 gray in 5 fraction as the new standard of care, and that was indeed very important, very handy and practical to all oncology centers around the world within the context of the COVID outbreak. But we have indeed continued even afterward when things settled as far as COVID is concerned, and this is still our standard of care for all 2 fields patients. So then we are addressing the fractionation issue in the context of DCIS. There is a study that has addressed this issue using 1525 as control arm versus the 16 fraction arm. And this report is still awaited, but the study took the opportunity to look at the role of boost in the context of DCIS as well. And this has been reported, showing that there is an improvement in local control of about additional 5 percentage points, but no improvement in terms of overall survival, which is not unexpected. But the overall benefit is still considered limited, and additional boosts need to be weighed against the patient's general health comorbidities and the fact that there is no impact on overall survival. So that is the issue of the fractionation, hopefully summarized these slides. So I'm going to move on to how can we de-escalate radiotherapy? And the first question comes to our mind is, can we omit radiation treatment altogether in selected group of patients? There were 2 main trials, the CALGB and the PRIME2. I'm going to talk about the PRIME2 specifically because they're very similar. And this is a UK and in fact Scotland-based trial. Patients over 65, under 3 centimeters, and overall low risk group, ER positive, HER2 negative, node negative, and randomized to radiotherapy versus no radiation. So it was a very simple, practical, straightforward design. And the 10-year data recently published shows that at 10-year point, there is 10% risk of local recurrence without radiotherapy, as compared to 1% with radiation treatment. So that is quite an important data that we need to take into consideration when we are discussing radiation treatment with these patients. And it's important as well to highlight, while there is no improvement in overall survival, but for those patients who are very fit and well with minimal comorbidity, a 10% at 10 years is significant to be considered, and particularly if we take into consideration that the fractionation has changed from 25 or 15 to 5. Whereas those who have significant comorbidities, their potential benefit from the additional radiation treatment in the context of low-risk cancer is likely to be very limited. The other aspect of de-escalation of radiotherapy is partial breast radiotherapy. And this can be addressed by number of techniques, including interstitial, the mammocyte, or the intraoperative techniques, and finally the external beam radiotherapy. The two trials that have been successful and reassuring, showing reassuring results, are the interstitial brachytherapy and the external beam, whereas the other two really did not show any advantage, and in fact there are concerns in terms of local recurrence, and therefore they are not considered part of standard of care. And also, from a practical point of view, the interstitial brachytherapy is far more challenging, requiring additional expertise, additional resources, and certainly challenging in terms of radioactivity and in terms of QA and so on. However, external beam radiotherapy, on the other hand, is far more practical, as no additional expertise are required. Same equipments and same machines can be used, but a slight adjustment of the technical aspect of it. So therefore, it does make sense, and certainly this is the direction in the UK, to consider using external beam radiotherapy as the preferred technique for partial breast irradiation. But if we look at these in more details in terms of trials, what you see there, the summary, is that the intraoperative trials, the first two, have looked at a single fraction in comparison to obviously multiple fractions, okay? And it does require far more complex techniques from a logistic point of view. Is highly demanding. The B39 trial, the issue with it is that it included much higher risk patients, including node-positive patients, and also the other issue is it has included number of techniques. So it allowed practically any technique you can use depending on the local center preference. And the other point to highlight, it used an accelerated fractionation. So there are a number of issues: higher risk population, different techniques, and acceleration, in addition to the fact that it is the volume question. The SHARE study and the RAPID trial are both looking at partial breast, but also within the context of accelerated hypofractionation. So therefore, these are all factors that confound the overall outcome. Whereas the two trials, the astrobrachytherapy, for example, it's one technique and addressing the question of partial breast irradiation. And I think it's even clearer when it comes to the import low trial, because it is one technique and one fractionation. The only question that is addressed in the import low trial is the volume question. And therefore, I'm going to focus more on this trial. As you can see here, there are two arms: the test 1, which is the dose gradient arm, and the pure partial breast arm in test 2. And the result from this study at the 5-year point showed that the test arms are non-inferior to the control arm, which is obviously very reassuring. And therefore, this could be considered the standard of care. The other message from this trial is that the dose gradient arm, which is test 1, didn't really have any advantage over the pure partial breast arm. And therefore, this is not an option, not a practical option, and it's reasonable to move directly for low-risk patients from whole breast irradiation into the pure partial breast irradiation. And this is currently the standard of care, and indeed it is very much complementary to the fast-forward trial showing that the 26 grain 5 fractions combined with partial breast irradiation certainly go hand in hand in de-escalating radiotherapy fractions as well as volume. On the other hand, we have another studies looking at escalating treatment. And one of the important one that I'd like to discuss with you is the Import High study, which is looking at the role of simultaneous integrated boost. Now, the standard of care in the control arm on the left-hand side is the sequential boost, with the background dose to the whole breast of 40 grain 15 with a 16 in 8 sequential boost, compared to a biologically equivalent dose to the boost of 3.2 gray per fraction, total 15. So this is an integrated boost. And then on the test 2, there is an element of dose escalation at the index quadrant. So it's addressing integration as well as escalation of radiation dose. The study is quite an important one, and the results, again, after 5 years of data, showed that the test arms are non-inferior to the control, and that is obviously very reassuring. It also confirmed that it is safe to consider simultaneous integrated boost. There's no additional toxicity, and in terms of cancer-related endpoints, there are no concerns either. However, the third message is that dose escalation did not make a difference, and therefore there is no point in escalating the dose of to the boost beyond, above and beyond what we currently do. Moving on to then nodal irradiation. Nodal radiotherapy is quite a challenging field as well, and is keep changing, and is influenced significantly by what we do from a surgical point and by the systemic treatment as well. But traditionally we have been reliant on 2 main trials, the MA20 and the EURTC. And both individually have shown an improvement in disease-free survival, but within a meta-analysis, there is also an overall survival impact. However, when you look at the specific impact of the internal mammary field addition to the other regional nodes that was addressed by the Danish study, you can see that there is an overall survival advantage with the addition of internal mammary irradiation and reduction in the breast cancer mortality. And therefore, for high-risk population, it's entirely reasonable to irradiate the undissected axilla, supraclav, as well as the internal mammary node. So this altogether hopefully provide you with a comprehensive, hopefully, view of the radiotherapy journey over the last 20, 30 years, and what is the evidence base for our current practice. But we need to look into the future, obviously, as well, and look at what future directions we have. Now, I'm sure most of you know that the Z11 study and all the controversies associated with that in terms of de-escalating axillary treatment in patients with relatively low volume nodal involvement. There were a lot of concern about the QA and a lot of debates about it. And in the UK, it was felt that it's important that we repeat that trial with a much better and more robust quality assurance program. And this is what basically the POSNOC trial has done. It has completed its recruitment, and with a very robust QA, as I indicated, and early results are expected in about 2 years from now. So it is comparing axillary treatment versus no axillary treatment in the context of 1 to 2 node positive disease. So it is likely that it will show non-inferiority, and is likely to impact on our practice and give us more confidence to de-escalate axillary treatment. Along the same lines, but in the neoadjuvant setting, the B51 study looking at patients who had node positive at baseline, who convert to node negative following systemic treatment, and then they are randomized into regional irradiation versus no regional irradiation. This study has now been reported last year in December, and what you can see is that all disease-related endpoints are equivalent, identical. There's no difference between the two arms, and in terms of toxicity, not surprisingly, there is less toxicity with no regional irradiation. So overall, this is quite important, very reassuring, but we do need more data about the study, particularly the QA and the radiotherapy component of it. So we await further data on that. And second, we do need long-term follow-up as well for this specific study. And in order to avoid being in the same situation as Z11 and POSNOC, as I indicated earlier, there was a consensus that there is a need to do another similar trial with, again, robust QA. And this is what is done by the ATNIC study in the UK, looking at the same population and randomizing patients to auxiliary treatment versus no treatment. It is recruiting relatively slowly, but about 30% of patients have already been recruited, but it will take a good, at least another 3 years to complete that. But watch the space. I think it will be very important, and I hope and expect, in my opinion, that it will confirm non-inferiority, but obviously we're going to need to wait for these results. Along the same lines, in patients who are node positive at baseline, but who do not convert to node negative status after their sentinel node biopsy, they are randomized to either completion auxiliary node clearance, which is considered currently the standard of care, versus auxiliary radiotherapy. So it's a form of de-escalating auxiliary treatment from surgery to radiotherapy, but the data, there are no data yet from this study, but it will be very important, and we all, I think, we are very interested to see the outcome. I mentioned earlier the fast-forward study, and that was for 2 field patients, and it has shown the efficacy of the 26 grain 5 fractions. But it was felt as important that we evaluate that fractionation in the context of nodal irradiation as well. And if it is safe and as effective and as toxic to control to the control fractionation, it's probably going to be the same in the nodal irradiation as well. But we needed to confirm that theory, and that is why the fast-forward lymph node sub-study has emerged, and in fact has completed recruitment to look at the efficacy, to look at the safety of nodal irradiation using 26 grain 5 fractions. So the data are very, I'm sure will be very interesting, and we all are keen and enthusiastic to see that, as it will have a major impact, in fact, on our practice. Because imagine that means if non-inferiority is confirmed, it means that we could potentially reduce the fractionation for all patients, regardless of the number of fields, to 26 in 5. And along the same lines, in order to take this further and have a comprehensive evidence-based practice, we need to know how we incorporate the tumor bed boost within the context of the fast-forward fractionation. As high-risk patients, particularly those who require nodal irradiation, are likely to require a boost. And currently we use simultaneous integrated boost as indicated in the import high trial. And that is what is used as a control arm here. But to use the fast-forward fractionation, is important that we address the concomitant boost in that context, and therefore using 31 grain 5 or 30 grain 5 fractions. This study is in setup and is expected to start towards the end of this year, and will no doubt have a major impact. And I would hope and expect there will be major interest from patients as well as a clinician regarding this study. And with this in mind, I'd like to thank you very much again for your attention, and I hope you have a great conference, and I will be delighted to address any of your questions.
Thank you, Dr. Abdullah. I'm hoping he will be available for a question and answer session. Now I would like to invite Dr. Naila Zahid. She is a professor of medical oncology at Liaquat National Hospital, Karachi. She will be talking about how to improve survival in metastatic triple negative breast cancer. Over to you, Dr. Naila. Thank you so much.
Assalamu alaikum. Good afternoon. I would like to thank the organizers for inviting me for this presentation. So I'm going to talk about how to improve survival in metastatic triple negative breast cancer. Triple negative breast cancer itself is a vast topic, and I'll try to do justice as much as possible. Just to remind everyone, triple negative accounts for about 15% of all breast cancers. And by definition, it has less than 1% expression of estrogen and progesterone receptors, and it is HER2 negative. It has an aggressive biology, higher grade, highly proliferative. It is more common in younger women, African Americans, and BRCA1 and 2 mutation carriers. It has a higher risk of early recurrence and lower survival rates. So what do we know about triple negative breast cancer? There are 4 molecular subtypes based on the DNA and RNA profiling: basal-like immune activated, basal-like immunosuppressed, mesenchymal, and luminal androgen receptor. These types have their own genetic mutations accounting for their different types, and they may have clinical implications right now. At the moment, we don't have any significance of this in the clinics, and there's no point of checking for them, but in future, these might be targets for treatment. And also, I would like to remind everyone that 75% of the triple negative breast cancers have basal gene expression, and 50% of the BRCA carriers are triple negative. So that's why people with triple negative breast cancers should have BRCA gene testing. So one thing which is characteristic, which makes it different from other types of breast cancers, is that triple negative breast cancers are immunogenic. They have a high tumor. I don't know. How do I go? इसमें pointer कैसे चलेगा? Well, pointer नहीं? Oh, I do it here. So it has a high tumor burden, which means that when there is a high tumor mutation burden, it attracts more immune cells, and therefore is associated with greater immune reaction to the tumor. And then T cell infiltration. The T cells are associated with generating the immune response, and triple negative breast cancers are typically rich in T cell infiltration and PD-L1 expression. The PD-L1 receptor on the tumor cells binds to PD-L1 receptors and down-regulates the immune response. We know that triple negative breast cancer is associated with shorter survival rate than the rest of the breast cancers. It has a higher probability of distant recurrence compared to non-triple negative tumors, and especially when it recurs, it's more recurrence in the lungs and liver and less in the bones as compared to the hormone receptor positive. Most of the recurrences occur early within the 3 years compared to non-triple negatives, and if someone is disease-free for 5 to 6 years, most likely they are cured of their disease, in contrast to hormone receptor positive, in which we see late recurrences. The good thing about triple negatives is that it is exquisitely sensitive to chemotherapy. We see about 45% response to chemotherapy in triple negative breast cancer. So how do we treat metastatic breast cancer? We have come a long way in hormone receptor positive and we have come a long way in hormone receptor positive so that the chemotherapy now comes in third line in hormone receptor positives. Similarly, in HER2 positive, we have a lot of targeted therapies. Still, we don't have that many options in triple negative breast cancer, and most of the treatment is still chemotherapy. Until about 5 years ago, when we started having 5 new drugs, which are PARP inhibitors, the antibody drug conjugates, and also immunotherapies. So prior to starting the treatment, it is very important we get a biopsy of the metastatic site and we do the markers, because sometimes there is a change in the markers at the time of recurrence. We should do the PD-L1 testing, and this should be with the 22C assay, because the drug that is approved in immunotherapy is pembrolizumab. If we do with 142, then it will be a waste. We won't be able to use it. Germline BRCA1 and 2 testing should also be done upfront in deciding treatment for triple-negative breast cancer. So here is the algorithm that we can now use in advanced triple-negative breast cancer. In the first line, if the PD-L1 is positive with a CPS score of more than 10, pembrolizumab plus chemotherapy, and if the PD-L1 is negative, then if patient has germline BRCA mutation, then olaparib or talazoparib. If no BRCA1 or 2 mutation, then chemotherapy. Whereas in second line, we have the antibody drug conjugates as well as chemotherapy and immunotherapy for high tumor mutational burden. So let's start with pembrolizumab plus chemotherapy. Pembrolizumab in combination with chemotherapy is FDA approved for patients with PD-L1 positive metastatic triple-negative breast cancer. And just to remind everyone that about 38% of the triple-negative breast cancer are PD-L1 positive with CPS score of more than 10. 60% are PD-L1 negative. And the chemotherapy options that can be used with immunotherapy are nab-paclitaxel, paclitaxel, carboplatin plus gemcitabine, or chemotherapy choice often depends on the prior chemotherapy exposure and timing. So how the immunotherapy works: the tumor cells expressing PD-L1 bind to PD-1 on T cells. So this is the tumor cell, this is the PD-L1 ligand on it. It binds to the PD-1 on the T cells and it turns it off. It deactivates the T cells, so the immune response cannot be generated. So when we use the immunotherapy, it blocks this PD-1. The immunotherapy binds to PD-1 antibody, and that's why the T cells are released and they are turned on. And now they can generate an attack on the tumor cells. And the good thing is that when the chemotherapy and immunotherapy can act synergistically, when chemotherapy kills tumor cells, the antigens are released into the blood. There is an increased immune cell infiltration. There is enhanced antigen presentation to the T cells. There is direct stimulation of T cells. And also there is depletion of immunosuppressive cells by the immunotherapy. So this way, it promotes the immune effect on the tumor cells. And we know that this is one of the new mechanisms. By harnessing the immune response, we can kill cancer cells. And this is one of an important mechanism against treating cancer. So the main, although there were many trials of immunotherapy with other agents like atezolizumab, which were done before this, the drug was approved for, I'm not going to go into the details, but everybody would remember Impassion 130 and 131, because of 130, atezolizumab was approved for the treatment of triple-negative breast cancer, and after 131, it was withdrawn because there was no survival benefit. Then finally, the Keynote 355, in which pembrolizumab plus chemotherapy was given in patients who were previously untreated, locally recurrent, inoperable, or metastatic triple-negative breast cancers. It included de novo metastasis or completion of treatment with curative intent more than 6 months prior to the first disease recurrence. Of note, it did not include patients who were getting any steroids or patients who had any active autoimmune disease, obviously, because if the immune system is activated, the disease will become worse. The patients were stratified, randomized 2:1 between pembro plus chemo versus placebo plus chemo. And the stratification factors were chemotherapy used with pembrolizumab, PD-L1 tumor expression, whether it was CPS more than 1 or CPS less than 1, prior treatment with same class chemotherapy in the neoadjuvant or adjuvant setting. And then the treatment was continued until the disease progression. And overall, there was a modest improvement in median progression-free survival with the addition of pembrolizumab, 7.5 versus 5.6 months, which was not significant. But in patients with CPS more than 10, there was a 4-month improvement in survival, 9.7 versus 5.6 months, with a hazard ratio of 0.65, which was a big gain. And then among patients with CPS of more than 1, the progression-free survival when they because the thought was that maybe if someone has CPS more than 1, still we may get some benefit out. But in patients with CPS more than 1, the benefit was not that significant. Then later on, when we looked into the overall survival for patients with the CPS more than 10, we still see a survival benefit 23 versus 16 months. Whereas in patients with CPS 1, there was no statistically significant overall survival improvement. So based on this, FDA approved pembrolizumab plus chemotherapy for triple-negative breast cancer metastatic patients with CPS score of more than 10. And here we can see these graphs again showing the significantly improved overall survival in patients with PD-L1 positive metastatic triple-negative breast cancer, which accounted for about 38% of all the triple-negative breast cancers in the study. And the other good thing about immunotherapy is that when we add it to the chemotherapy, it has a different side effect profile. It does not cause that much myelosuppression. All the effects are related to activation of the immune system. There may be thyroid-related issues. There may be skin rashes, shortness of breath or coughing, diarrhea, abdominal pain. So it's a different spectrum of side effects as compared to chemotherapy, and therefore it's manageable. So having talked about the PD-L1 positives, now PD-L1 negative. In PD-L1 negative, again, we should get the BRCA1 testing upfront. And if the patient has BRCA positive disease, which is in 20% of patients with triple-negative breast cancer, 2 oral PARP inhibitors are approved for metastatic disease, olaparib and talazoparib. What are PARP inhibitors? So in a normal cell, what we see here that there are 2 mechanisms for repair. One is the base excision repair through PARP, and the other one is homologous recombination through BRCA1 and 2. So if these 2 are functioning properly, the cells grow healthy. And if these don't work properly, there is DNA damage, and this causes cell death. When patient has BRCA1 or 2 associated cancer, the BRCA part is gone. So there is no homologous recombination pathway for the repair of the cell. And the cell is depending only on PARP for the base excision repair. And then when we use PARP inhibitor, this path is also blocked, and there is no way to repair the DNA damage. And this DNA damage then accumulates and causes cell death. So this is the basic mechanism behind it. So there were 2 important phase 3 trials with PARP inhibitors. One is the Olympia trial, and the other one is EMBRECA trial. Olympia trial used olaparib, and EMBRECA trial used talazoparib, and both of them had patients with BRCA1 or 2 mutations. In Olympia, they had used up to 2 lines of treatment, whereas in EMBRECA, they had up to 3 lines of therapy. And the PFS was 7 months versus 4.2 months in the Olympia trial, and 8.6 months versus 5.6 months within EMBRECA, about 3 months improvement in survival, which was statistically significant with a hazard ratio of 0.58 and 0.54. And here we can see further that both olaparib and talazoparib significantly improved progression-free survival in these patients HER2-negative metastatic breast cancer with germline BRCA1 and 2 mutations. So FDA approved olaparib or talazoparib in these patients, but still, if someone if someone has BRCA mutation and we are using PARP inhibitors, the response is not 100%. One should remember this. So if someone does not respond to PARP inhibitors, that you should immediately switch them to chemotherapy. Also, if someone is chemo naive, in such patients also, you may start with chemotherapy first, because the studies do not compare with the first-line treatments like anthracyclines and taxanes. So we don't know if they are better than anthracycline or taxanes, the PARP inhibitors. And then if the patient is in visceral crisis, also you should be using chemotherapy first and then think of using PARP inhibitors later. If the patient has no BRCA mutation, then we go with chemotherapy. These are the different chemotherapy drugs, which I think pretty much everyone knows: taxanes, anthracyclines, platinum agents, capecitabine, eribulin, vinorelbine, gemcitabine. And should we be using a single drug or a combination chemotherapy? So this trial, E1193, compared combination chemotherapy of doxorubicin paclitaxel to single-agent chemotherapy doxorubicin or paclitaxel in patients with metastatic breast cancer. And the combination chemotherapy, although improved overall response rate, but it did not improve overall survival. And it was associated with more side effects. So you really have to select patients, in which patients you are going to use combination chemotherapy, maybe the ones in whom there is a higher chance of response, and it outweighs the higher risk of treatment toxicity, or maybe if you have a frail elderly patient, you want to go with a single drug. So really you have to decide according to individual patients. How do you sequence these chemotherapy drugs? Again, this is based on how the data have come. There is no comparison, but we know the oldest treatments are anthracyclines, then taxanes, platinum, eribulin. So maybe you can go in this sequence of order in using these drugs. So anthracycline, alkylator, and taxane-based chemotherapy regimen remains the most common, because with the studies, they have been proven. And so far, there is no study in which a non-alkylator regime has been found to be better than the alkylator regime. GCAM 9906 compared FEC with, sorry, my slide is a bit out of order. So GCAM compared FEC with FEC followed by taxanes, and taxanes improve the survival. So that's why we should always, once we have used anthracyclines, we can use taxanes in these patients. And similarly, in the ABC trial, they compared anthracycline taxane-based regimen to docetaxel cyclophosphamide, and the patients who received anthracyclines did better. So in triple-negative breast cancer, anthracyclines is an important part of chemotherapy drugs that we use. Then the TNT trial, because we always wonder about is the carboplatin and the platinum compounds that maybe with triple negatives, platinum compounds should be used earlier. We do have a lot of data in the early breast cancer, but in metastatic setting, in this trial, in the TNT trial, they randomized patients to first-line carboplatin or first-line docetaxel. And although, but the survival was similar in both the groups, maybe because the patients were switched to the other drug at the time of progression. But when these patients were stratified according to their BRCA status, it was found the patients who were BRCA positive had a better progression-free survival with platinum as compared to non-platinum. So this is something that one would think that if someone has BRCA positive and you were using chemotherapy, maybe platinum will be better to use upfront. So now coming to the second-line treatments, mainly the antibody drug conjugates. So what are exactly antibody drug conjugates? Here, basically, we can see that this is the antibody, and which is bound to a cytotoxic drug through a linker. So the antibody binds to a receptor on the tumor cell, and then it is taken in and it releases the cytotoxic drug inside the cell, therefore increasing the effectiveness of the chemotherapy and at the same time minimizing the toxicity to the normal tissue. The first of this was sacituzumab govitecan, which is an antibody drug conjugate that targets TROP2. It is expressed in majority of triple-negative breast cancer, and there is selective delivery of chemotherapy SN38, which is a active metabolite of irinotecan. And FDA approved it for all patients with metastatic triple-negative breast cancer who have received at least 2 prior chemotherapies. So this is the trial, Ascent trial, in which there were 529 patients who had previously received at least two different chemotherapies for advanced disease, and they were randomized to either SG or the treatment of patients' physician's choice. The stratification was the number of prior chemotherapies, geographic region, presence or absence of brain metastasis. And here we can see that the patients who received SG had better overall survival compared to single agent chemotherapy. So, and this was a significant difference. If you look here, 12.1 versus 6.7 months. So double the overall survival with SG. Another antibody drug conjugate is trastuzumab deruxtecan, which is also called Enhertu. It is a drug conjugate that targets HER2 for the selective delivery of chemotherapy drug deruxtecan. The interesting thing is that up till now, anti-HER2 therapy was considered only in patients with HER2 positive disease. So, but now we know that this drug is active in HER2 low breast cancer also. And what is HER2 low breast cancer? We know that there is an entity HER2 positive, there is an entity HER2 negative, but then there is one entity which is IHC 1 plus or 2 plus with negative FISH. This is HER2 low, and it comprises about 50% of the breast cancers, which is quite a big number. And And HER2 low expression is dynamic. Some at the time of primary breast cancer, a tumor may be HER2 negative, and then it becomes HER2 low at the time of relapse. Whereas a tumor which is HER2 low at primary breast cancer may become HER2 negative at the time of relapse. So that's why we have to repeat a biopsy in metastatic setting to make sure. So if someone has relapsed and we go back and look at the report and we say, oh no, the tumor was HER2 negative, so this is so we can't offer them an HER2. No, that's not correct. We should do a repeat biopsy before deciding about this. So this is the trial, Destiny Breast 4 trial, which is a remarkable trial in which patients were randomized 2:1. Patients were HER2 low, IHC 1 plus or IHC 2 plus, ISH negative, treated with 1 to 2 prior lines of therapy. Hormone receptor positive disease hormone receptor positives were also included, but greater number of patients were triple negative. So they were randomized 2:1. And here we can see the curve in these patients. Again, there was a significant improvement in overall survival in patients with triple negative breast cancer, a difference of 9.9 months in patients who received TDXD. If you look at all the patients in this group also, there was a difference of about 6.6 months, but the difference was greater in the triple negative breast cancer. So this was also approved for the treatment of triple negative breast cancer patients in second line setting. So for now, we can look at it at the algorithm. In the first line, we have PDL1 positive chemo plus pembro, PDL1 negative patients, taxane or platinum, and BRCA mutation, olaparib or talazoparib. In the second line, we can give antibody drug conjugate or this or BRCA mutated patients. And third line setting, we can give chemotherapy. So this is where we are going. And then I also want to mention Dato-DXd, which is another antibody drug conjugate, which is in pipeline, which is basically a hybrid between SG and TDXD, because the antibody is anti-TROP2, whereas the chemotherapy drug is deruxtecan. So it is actually a hybrid between those other two. And in this also, in these heavily pretreated patients, there was a 32% response in overall response rate. So this is also interesting. So in future, maybe we might be looking at something like this: sacituzumab govitecan, Dato-DXd, or BRCA mutated patients olaparib in the second line, and then chemotherapy coming in the third line, and also getting TDXD over here. So this is obviously I think we have going to have a very good future even for triple negative breast cancer once these drugs come in. What's the future? So what we don't know now, because with so many antibody drug conjugates coming up, what should be the sequence of antibody drug conjugate? Kisko pehle use karne, kisko baad mein? Optimizing the management of antibody drug conjugate related toxicities. We think that, we are so excited, but these have different toxicities. Like TDXD is associated with severe pulmonary fibrosis, and one has to be monitored, the patient has to be monitored very closely. Similarly, SG can cause necrotizing colitis. So we have to know the side effects and also how to manage and avoid them. And then how about now that we are going to have these new drugs, maybe combining antibody drug conjugates, PARP inhibitors, checkpoint inhibitors? There are so many trials going on. We really have to keep ourselves tuned. These are so many other targets which might be useful. So conclusion, historically limited treatment options for triple negative breast cancer. Advances in immunotherapies, targeted therapies, and antibody drug conjugates have revolutionized the treatment landscape. Incorporation of triple negative biology in clinical practice and clinical trials aim to personalize treatment and further improve outcome for patients living with triple negative breast cancer. Thank you.
Thank you so much, Dr. Naila, for excellent talk and thoughtful discussion on triple negative breast cancer. Now, I would like to invite Dr. Shahina Dawood. She is consultant medical oncologist working at Mohammed bin Rashid Medical University of Medicine and Health Sciences, Dubai. She would be talking about management of HER2 positive metastatic breast cancer, current evidence, and future perspective. Over to you, Dr. Shaheen.
HER2-positive breast cancer, really looking at the current landscape in 2024. These are my disclosures, and if anyone would like to get in touch with me offline, please scan the QR code, and I'd be more than happy to network offline. So as you know, the landscape of HER2-positive breast cancer has certainly changed in the last few decades. In the absence of any anti-HER2 therapy, the prognosis related to HER2-positive breast cancer used to be a lot worse than those patients with HER2-negative breast cancer. But that really changed with the introduction of trastuzumab. And as you remember, Slayman and colleagues published this very important paper way back in 2001, looking at the combination of trastuzumab plus chemotherapy versus chemotherapy alone in those patients with HER2-positive breast cancer. And you can see a significant improvement in the progression-free survival as well as overall survival of patients. We then saw the results of the Cleopatra study. The Cleopatra study took it one step forward, looking at the combination of two anti-HER2 agents in the form of trastuzumab plus pertuzumab versus trastuzumab alone, both in combination with chemotherapy. And you can see that using dual anti-HER2 blockade in the setting of metastatic breast cancer HER2-positive status in that first-line setting significantly improved overall survival of patients. And you can see the absolute difference was about 16.3 months. Now, since the introduction of trastuzumab, we've seen a plethora of different anti-HER2 agents, including trastuzumab, pertuzumab, T-DM1, lapatinib, neratinib, tucatinib, and of course, the new kid on the block, trastuzumab deruxtecan. But the question is, could we do better in terms of improving the prognostic outcome of patients with metastatic HER2-positive breast cancer? Well, the best way to do this is by optimally integrating those newer agents that are targeting the HER2 pathway. And to do that, it's by building an ideal treatment algorithm based on the available evidence. So I think these are the important questions that we need to ask ourselves. We know that Cleopatra essentially set the standard for the treatment of patients with first-line therapy in that HER2-positive realm, where you give pertuzumab, trastuzumab plus chemotherapy. Question is, how do we optimally approach a patient who's got a disease-free survival of less than 6 months or has progressed post-Cleopatra in that first-line setting? Well, in 2012, we did see the results of the Amelia study. The Amelia study took patients in that second-line setting, again, HER2-positive status, and they were randomized to get either T-DM1 or lapatinib plus capecitabine. And you can see a clear-cut improvement both in progression-free survival as well as overall survival, favoring the group of patients who were getting T-DM1. Question then came, can we do better than T-DM1 in that second-line setting? Well, we know that T-DM1 is an antibody-drug conjugate, but then we saw the development of second-generation antibody-drug conjugates, such as trastuzumab deruxtecan, that has a payload with a different mechanism of action. It has a high potency of payload, a high drug-to-antibody ratio, a payload with a short systemic half-life, a stable linker payload, a tumor-selective cleavable linker, and most importantly, a bystander effect. Question then came, we've got the second-generation antibody-drug conjugate, and then we asked ourselves the question, could trastuzumab deruxtecan work post T-DM1? Well, for that, we have the results of the Destiny Breast 01 study, which was an open label study that all patients had received prior T-DM1 and then were given single agent trastuzumab deruxtecan. And you can see in this particular trial, the progression-free survival was about 16.4 months with an overall survival that was not reached. 02 study that essentially randomized patients who had progressed on T-DM1 to either physician choice of chemotherapy or trastuzumab deruxtecan. And you can see that in terms of the primary endpoint of progression-free survival, there was an improvement in progression-free survival from 6.9 months with physician choice of chemotherapy to 17.8 months in terms of trastuzumab deruxtecan, resulting in an absolute difference of 10.9 months. In terms of the overall survival, again, you can see a significant improvement in terms of overall survival, favoring the group of patients who are getting trastuzumab deruxtecan. And you can see that absolute difference was about 12.7 months. Now, we knew that trastuzumab deruxtecan worked post-progression on TDM1. Can we do better than TDM1 in that second-line setting? Essentially asking the question, can trastuzumab deruxtecan actually replace TDM1 in that second-line setting? And that set the stage for the Destiny Breast 03 trial. In this particular study, they took patients again with metastatic breast cancer, HER2 positive, who had been treated with trastuzumab and a taxane in that advanced metastatic setting. Patients with brain metastases could be enrolled, but they had to have clinically stable and treated brain metastases. Patients were randomized to get either trastuzumab deruxtecan or TDM1 in that second-line setting, with a primary endpoint in the study being progression-free survival. And you can see in terms of the primary endpoint, a very nice separation in the Kaplan-Meier curves, and more importantly, a very early separation in that Kaplan-Meier curves, favoring the group of patients who are taking trastuzumab deruxtecan. You can see that there was a 22-month improvement in progression-free survival that translated into an almost 67% reduction in the risk of progression of disease. You can see even in terms of clinical benefit rate, it improved from 46% to 89%, favoring the group of patients who are getting trastuzumab deruxtecan. In terms of those key subgroups, you can see the PFS was improved in almost every subgroup of patients, whether they had hormone receptor positive or negative disease, whether they had visceral disease or not, or whether they had brain metastases or not. Every patient was actually benefiting with the use of trastuzumab deruxtecan. And this PFS benefit, in fact, also translated into an overall survival benefit with the use of trastuzumab deruxtecan. And you can see an almost 36% reduction in the risk of death from disease when used TDXD versus TDM1. So let's sort of put it all together. We know that the first-line setting, established standard of care, is Cleopatra, where you use pertuzumab, trastuzumab, and chemotherapy. In that second-line setting, we had the results of the Amelia study that told us that TDM1 was better than lapatinib and capecitabine. You can see an improvement in the PFS from 6.4 months to 9.6 months. And now we have the results of the Destiny Breast 03 trial that tells us that TDXD further improves the PFS to almost 28 months. Now, if you gave TDXD in that third-line setting instead of the second-line setting, you're still getting a very good PFS, but you can see that that PFS is actually half of what you're getting in that second-line setting. So let's look at a case study. This is a 35-year-old lady with stage 3 HER2 positive breast cancer diagnosed in 2018. She got chemotherapy plus her anti-HER2 therapy and underwent surgery. She was put on endocrine therapy since her disease was HER2 positive. But unfortunately, by 2020, she presented with back pain and she was found to have bone mets. At that point, we did treat her with Cleopatra, giving her chemotherapy plus trastuzumab plus pertuzumab. And because she had endocrine sensitive disease, we then gave her maintenance therapy with trastuzumab, pertuzumab, and fulvestrant. By 2021, she had progression in one bone met. We radiated that area of illegal metastases and continued fulvestrant plus trastuzumab and pertuzumab. But unfortunately, by 2022, she had progression both in her bone as well as her liver. And you can see from the scan extensive liver metastases. And the question that we asked ourselves at that point, were we going to give her chemotherapy plus trastuzumab, pertuzumab? Were we going to change the endocrine therapy backbone? Were we going to do an Amelia-style protocol where we gave TDM1? Or are we going to shift to trastuzumab deruxtecan? We commenced her on trastuzumab deruxtecan in March of 2022, and you can see that by June of 2022, Her MRI abdomen actually showed a complete response. And by July 2024, she'd received her 40th cycle of TDXD. And I can tell you, I saw her last week and she continues to do very, very well. So we know that Destiny Breast 03 supports the use of TDXD being the superior HER2 antibody drug conjugate and the preferred second-line therapy for patients with HER2-positive metastatic breast cancer today. The question that we don't know, that we don't have the answer of, is will TDM1 work post-progression on trastuzumab deruxtecan? There has been some retrospective data that has come out that was presented in multiple poster sessions at ASCO this year. However, we still don't have any prospective trial that has told us whether TDM1 will work effectively post-TDXD. The next question we asked ourselves, we know Cleopatra is a first-line treatment for patients with HER2-positive breast cancer. We know that TDXD is now established second-line treatment for patients with metastatic HER2-positive breast cancer. What is the optimal strategy to manage these side effects associated with TDXD? Because it's a very unique drug with very unique side effects. So I think these are some of the questions that we probably ask ourselves as physicians. Do we need to continue to monitor the cardiac function in these patients that we do typically with trastuzumab and pertuzumab? And the simple answer is yes. You can see that about 2.7% of patients in the Destiny studies did have an adverse event in terms of a reduction in the left ventricular ejection fraction. So you do need to continue to monitor the ejection fraction in your patients. Then what are the unique side effects of trastuzumab deruxtecan that is specific to this antibody drug conjugate? Well, when you look at the Destiny studies, you can see that although neutropenia does occur, you can see febrile neutropenia is actually quite a rare event associated with TDXD. Now, nausea and vomiting is something that is significant with TDXD, and I think one should have good anti-nausea protocols when you're treating your patients with TDXD. Fatigue can be very, very significant, and it's important to recognize and counsel your patients about the fact that this does happen in patients taking TDXD. Alopecia is also quite common, although most patients don't go completely bald, but they do have significant hair thinning. Again, important to counsel your patients about it. And then, of course, interstitial lung disease does tend to happen at a higher incidence associated with TDXD compared to other medications. So how can we as community oncologists optimally detect and manage interstitial pneumonitis? Well, we first need to recognize that some patients are going to be at a higher risk of developing pneumonitis, including those patients who are smokers, who are at advanced age, who have a history, an underlying history of interstitial lung disease. Male patients have a higher risk, and of course, ethnicity does matter. Now, there has been a number of guidelines that have looked at the management of patients who are getting interstitial lung disease when they're treated with TDXD. I think these are the best guidelines that have been actually published. And I wanted to put to you two case studies that was actually published with these guidelines to sort of tell you when and where interstitial lung disease can actually happen. So this is a patient with stage 4 refractory HER2 mutant lung adenocarcinoma who was treated with TDXD, and you can see his CT scan at baseline, and 2 weeks post giving TDXD, he's developed significant interstitial lung disease, and he required steroids for treatment. This is another patient also with lung cancer that was treated with TDXD, and you can see that he managed to develop interstitial, or the beginning of interstitial pneumonitis about 10 months post starting TDXD, really essentially telling us that the median onset in patients who are getting interstitial pneumonitis about 149 days, but it can actually be rapid interstitial pneumonitis. It can be delayed. And it is important to pick it up as early as possible and to manage it appropriately. How do you manage it? If you're suspecting someone to get interstitial pneumonitis, the first thing is do not panic. These patients can be treated if picked up early. Second, you need to monitor your patient appropriately, and you need to stop the drug immediately. You then need to confirm that your patient actually does have interstitial pneumonitis. And you usually work with your pulmonologist to get those investigations done, which could include a high-resolution CT scan and, of course, a proper pulmonologist consultation. Then this is the algorithm that you usually use to treat your patients with interstitial pneumonitis. I'm not going to go over it in detail, but suffice to say that first interruption of the drug and steroids are the two key important ingredients of treating your patient who has interstitial pneumonitis. So first line treatment, Cleopatra. Second line treatment, Destiny Breast 03 with T-DXd. If your patient progresses, what is the optimal third line treatment in patients with HER2-positive metastatic breast cancer? And I think for that, we have the results of the HER2-CLIMB trial, which took patients HER2-positive metastatic breast cancer who had been treated with trastuzumab, pertuzumab, as well as T-DM1. And patients with brain metastases, both treated and untreated, were included in this trial. Patients were randomized to get either tucatinib plus trastuzumab and capecitabine, or trastuzumab plus capecitabine. And you can see the primary endpoint of this trial was progression-free survival. And very clearly, you can see on this slide over here that using the triplet combination of tucatinib, trastuzumab, and capecitabine significantly improves both progression-free survival as well as overall survival in that third line setting. Now, one of the questions that's going to become so important in 2024 and going forward are patients with HER2-positive breast cancer are surviving a lot longer because we've essentially converted this disease into a chronic disease. And these patients are going to now develop CNS metastases. How are we going to deal with CNS metastases? We know in these patients with HER2-positive breast cancer, approximately 50% of these patients will eventually develop CNS metastases. And what I've done here is I've essentially collated a lot of the information that's come from the trials that have looked at anti-HER2 therapy. And if you focus on HER2-CLIMB and Destiny Breast 03, you can see that the CNS overall response rate in HER2-CLIMB was about 47%, and with T-DXd in Destiny Breast 03, it was 63.4%, telling us these two agents have activity in the brain. When you go back to the HER2-CLIMB, remember I told you these patients did have either active or non-active or a stable treated brain metastases. And you can see whether a patient had active brain metastases or stable brain metastases, giving the triplet combination with tucatinib, trastuzumab, and capecitabine did improve prognostic outcome of these patients compared to using trastuzumab plus cape. Now, what about trastuzumab deruxtecan? Does it work? I just showed you some very impressive CNS overall response rate. Well, Sarah Hurwitz actually presented this data in ESMO 2023, looking at a pooled analysis of patients who had brain mets enrolled in Destiny Breast 01, Destiny Breast 02, as well as Destiny Breast 03. And you can see that T-DXd actually demonstrated a trend towards prolonged CNS progression-free survival compared to its comparator, with noticeably greater advantage for patients who had untreated or active brain metastases. You can see those Kaplan-Meier curves are literally separating very, very early and are very, very widely separated. I absolutely love this study, and I think it's one of the most underrated studies, but actually helps the community oncologists see what they can do in the clinic. This is the DEBORAH trial. The DEBORAH trial took patients with HER2-positive breast cancer in different cohorts, that means different clinical setting. The first cohort actually took patients with HER2-positive breast cancer with stable brain metastases, having been treated with surgery or some form of local therapy, and then received trastuzumab deruxtecan. And you can see the 16-week progression-free survival rate was 87.5%. In the second cohort, they took patients with untreated HER2-positive brain metastases, but that were asymptomatic. So they had no symptoms, but were not treated, and were then treated with trastuzumab deruxtecan. Overall response rate in the intracranium was 50%. The third cohort were those patients who had brain metastases that progressed post local therapy, and then were treated with trastuzumab deruxtecan, Again, the overall response rate in the intracranium was 44.4%. So you can see different clinical scenarios. TDXD worked in those different clinical scenarios in the brain. So just putting it all together, you can see that different studies looked at different approaches to use TDXD for patients with brain metastases, but across the board, and you can see the blue bars represent patients with active brain metastases, and the green bars represent patients with stable brain metastases, and across the board, TDXD was working in both cohorts of patients. So this year at ESMO, we saw, I thought, the most important trial that was presented at ESMO, which was the Destiny Breast 012 study that took patients. This was a phase 3b/4 study, a multi-center, single-arm, two-cohort, open-label study that took two cohorts of patients. The first were patients with brain metastases that included both patients who had stable brain metastases but were previously untreated, or patients with active brain metastases, but again, either untreated or progressing on some form of therapy that they had been given before. The second cohort of patients were those patients without brain metastases. Both cohorts were treated with TDXD. We will focus on those patients who were enrolled who had brain metastases. You can see the primary endpoint was progression-free survival. When you looked at the progression-free survival as in the overall population of patients with brain metastases, you can see a very nice PFS of 17.3 months. Look at that 12-month progression-free survival in those patients with active brain metastases. It was almost 60%. And in a post-hoc analysis, those ones that had active untreated brain metastases was 47%, and those with previously treated but progressing brain metastases were almost 66% 12-month progression-free survival. Then when you looked at the CNS PFS, you can see the 12-month CNS PFS was 58.9%. And again, looking at those patients with the active brain metastases, the 12-month CNS PFS was almost 60%. So I think some very impressive results. And then you can see the overall survival of those patients with baseline brain mets overall. The 12-month overall survival was 90%, something that we hadn't seen before in our patients. Post-Cleopatra, if a patient has active brain metastases and there's no role for any local therapy, CNS, you could think about using the triplet combination with tucatinib. If no CNS disease, I think you have various options, including tucatinib-based, or perhaps even re-challenging with TDM1. Now, post-Cleopatra, if a patient has active brain metastases and there's no role for any local therapy, I think I'm going to change this algorithm now based on the Destiny Breast 012 trial, because I think even if there is a role for local therapy, I think one could think about going straight into TDXD. And I think these are the questions that we're going to ask ourselves in the MDTs. But suffice to say, you have the triplet combination as well as TDXD available to you in patients with active CNS metastases. Of course, in heavily pretreated patients, you need to continue to suppress the HER2 pathway. And there's so many different combinations out there that one could think about. And do not forget, there will be some patients in the early stage setting that will relapse only in the brain. And these patients, again, need to be discussed in the MDT to see whether you're going to approach them with local therapy or systemic therapy. So thank you very much, and I'm happy to answer any questions. And again, you can scan my QR code if you want to get in touch with me offline. Take care.
Thank you, Dr. Shahina, for a nice presentation. Now I would like to introduce Professor Mohammad Janzeb, who is Professor of Medical Oncology at Florida Atlantic University, USA. I think he is the most popular oncologist who is multi-talented, but today he will be in Pakistan. Today he will be talking about metastatic hormone-positive breast cancer. Over to you, Dr. Janzeb.
Hello, everyone. Greetings from Florida. I wish I could be there in person, but be that as it may, I'm thankful to the organizers for including me. This is the topic that's given to me, and in 20 minutes or less, I have to go over a lot of material, so let's get to it. The basic guiding principle is that you're not going to cure metastatic hormone receptor positive breast cancer, but it is important to tell the patients the median survival now exceeds 5 years so that we can give them some kind of hope. And in fact, those on the longer end of the spectrum can live many more years than that. And we should try to do as little as possible for as long as possible while maintaining quality of life in these patients and not rush to chemotherapy. Many lines of hormonal therapy work. There's very little reason to not exhaust all lines of hormonal therapy or now targeted therapy before we resort to chemotherapy. So when you look at the spectrum of the disease, it goes on the left-hand side from very indolent, slow biology of disease, somebody who finished their adjuvant treatment, let's say 5-10 years ago, and they have minimal tumor burden, bone-only disease, etc. Those patients do the best. And then with increasing tumor burden and decreasing interval from primary therapy to relapse and increasing tempo of disease or weaker and weaker hormone receptor positivity, we shift towards the right side of this spectrum, where in the red box on the extreme right, you see patients who have fast progressing, life-threatening aggressive disease. So we have to, in our mind, categorize patients into these boxes and decide how aggressive do we need to be with this particular patient. NCCN guidelines now appear complicated, busy, but it's really very simple. In the left-hand column of the large box, you see that there's 3 CDK4/6 inhibitors that can be used either with an AI or with a fulvestrant, although category 1, which is high level of evidence and complete consensus of the panel, is only earned by ribociclib and abemaciclib. Second and subsequent line, you use CDK4/6 if you didn't use it in first line, and targeted therapies are options. And then the right-hand column gets to single agents most of the time. And there are some targeted options there, but whichever hormonal agent was not used in the first line or second line can be used in subsequent line of therapy. And in the bottom part of the middle column, you also see useful in certain circumstances, which is drugs and options that NCCN does not like for use in the United States, but they leave them in the guideline such that if there are other countries with limited options, that people remember that these are also options that have been used in the past and can work in a patient. The Right Choice trial looked at how soon should we rush to chemotherapy. And this was a multinational randomized phase 2 trial comparing chemotherapy doublets. In other words, these were patients who were younger, perimenopausal, premenopausal with visceral disease, where you are worried about the patient and you're not even comfortable using single-line chemotherapy, single-agent chemotherapy. You want to combine them into doublets. And those patients had an experimental arm of ribociclib with endocrine therapy. So these chemo doublets were docetaxel, capecitabine, paclitaxel, gemcitabine, capecitabine, vinorelbine, and PFS was the primary endpoint, secondarily time to treatment failure, and these other endpoints listed here. And you can see that surprisingly, ribo with an AI performed better, and there was a 8 to 9 month improvement in PFS. And the bottom curve shows time to treatment failure, which takes into account discontinuation of treatment due to toxicity or patient refusal or for any reason. And you can see even there was more than a doubling of time to treatment failure in favor of ribociclib and AI. This would have been counterintuitive, but now it gives us that option of not using chemotherapy. Now, when you look at what worked faster, chemo did work a little bit faster. 3.2 months was time to response versus 4.9 for the ribociclib arm. Survival is not mature, as you see here, and response rates were slightly higher, actually, for numerically at least, for ribociclib. And on the right-hand side, you see that the adverse events were worse with combination chemo. Those more modifications were required more in the chemotherapy arm. In fact, nobody had a third dose reduction in ribo arm, but 20% of patients had third dose reduction or greater in the combination chemo arm. So if progression doesn't get delayed by chemo, and toxicity is more on both of those accounts, chemotherapy loses. So this should give us pause to pick the chemotherapy option. NCCN guidelines, however, still for visceral crisis or endocrine refractory disease recommend systemic chemo unless patient has BRCA mutation or these other targets, which are shown better on this slide. We had only 3 biomarkers for breast cancer, and now we have added 9 more to them, for which there are FDA-approved drugs for all of them, from PIK3CA, AKT, PTEN, ESR1 mutation, germline BRCA1 to NTERC, MSI high, tumor mutational burden, and RET fusion. So now we have to be mindful of all these. Therefore, we should be sending NGS testing on patients to not miss any of these, particularly the PIK3CA, which is as high as 40% in breast cancer patient population that's hormone receptor positive. But the 4 at the bottom are very infrequent, less than 1% or 0.3% of patients. So we can afford to miss those, but it's nice to know all of them to make decisions. SONIA trial asked the question whether everybody should be on CDK4/6 in frontline, or can we reserve it for second line and not lose in terms of overall survival? Obviously, we already know we are going to lose on PFS. That was the design of randomized trials. So as a result, first-line PFS on the left-hand panel is no surprise. We know that CDK4/6 plus AI gives you 2 years or longer, slightly longer than 2 years PFS. And AI in those trials gave 11 to 12 months. Here it performed a little better and gave 16 months. But that curve is not surprising. What's surprising is the PFS2 was very similar, no matter which approach you took. 27 months for second-line CDK4/6 versus 31. So this gives us an additional option if financial toxicity is a huge issue, and which I know is in most countries where patients are paying out of pocket. In the United States, everybody has insurance, and insurance covers CDK4/6 inhibitors. So we would rather delay progression as much as possible, because taking the second approach means that you don't really care about progressing in 11, 12, or 16 months rather than 24, 27 months. So that's something to keep in mind and have a discussion with the patient. The other question has been, can we use a different CDK6 inhibitor after progression on a CDK4/6, or even the same one in case of palbociclib, because that was first to market. So the middle 2 trials are practically giving palbo after progression on palbo. So they were negative studies, but the ones in the other columns, first column and the fourth column, you use a different one, ribociclib in maintain trial and abemaciclib in post-monarch. And this was at ASCO 2024. We learned that post-monarch actually had 12.9 versus 5.6 month PFS with a hazard ratio of 0.55, and that was statistically significant. Capitello trial looked at capivasertib with fulvestrant versus placebo fulvestrant in patients who had failed prior hormonal therapies up to 2 lines, even could have 1 line of chemo. Prior CDK4/6 were desirable for at least 51% of the patients, actually ended up being 70% of the patients. And PFS by investigator was the primary endpoint, along with AKT pathway altered tumors. So those were dual primary endpoints. Key secondary endpoints were overall survival and objective response rate. And here's the overall patient population on the left and the altered population on the right. While both curves are separated and median PFS seems similar, going from over 3 months to over 7 months, all of this was driven mainly by the altered population. So that's the label of the drug, is only for those with alteration in PIK3CA, AKT, and PTEN. When you put alpelisib side by side with this trial, which was the first drug to be approved for PIK3CA mutations, you see that curve separations look similar, but the populations are very different. Only 6% of alpelisib exposed patients had prior CDK4/6, whereas 70% of patients had failure of prior CDK4/6 in the capivasertib study. And that's why the numbers for PFS look lower, 3.1 versus 7.3 months, as opposed to 5.7 versus 11 months. When you look at the toxicity, focus on hyperglycemia, which was a huge problem with alpelisib, grade 3 or more hyperglycemia in more than a third of patients, 36.6%, as opposed to only 2.3% with capivasertib. Other toxicities are in the same ballpark. ESR1 mutations are very uncommon in no more than 1% of patients if they are de novo. Once patients have been treated with hormonal therapy with an AI in the adjuvant setting, it can go up to 5% at the time when they relapse. But if patients are treated with a couple of lines of metastatic therapy with aromatase inhibitors, it can be as high as 40%. And that mutation confers ligand-independent ER activation, as shown in red on the right-hand side in this pathway. So it doesn't require the estrogen to bind to it. Pathway is active on its own. And now we have a drug, elacestrant, which can work in these patients. And this randomized trial was carried out just to show that these were patients who could or could not have the mutation for enrollment, but mutation was tested in this patient population. They got elacestrant 400 milligram daily orally. It's an oral agent, or investigator's choice of fulvestrant, anastrozole, letrozole, exemestane, whichever one they had not received before, and co-primary endpoints for PFS in all patients and PFS in mutated patients. And all patients shown on the left, those curves are not as separated as patients with tumor harboring the mutations on the right-hand side. So even though both p-values are significant, hazard ratio is better on the right, and largely the benefit was driven by patients with the mutation. So only those patients are approved to receive this drug. An interesting follow-up analysis was presented at San Antonio meeting in 2022. And patients who had been exposed at least 6 months to a CDK4/6 inhibitor before they progressed, that would be much worse population than those who stayed on it for a year or year and a half, 12 months, 18 months, as shown on the right. And you see how the curves are much more separated in those patient populations. So this way you can predict who is at a greater likelihood of benefit or not. It's a very common dictum in oncology. Those who do poorly will do worse than those who have done well previously will continue to do better. Antibody drug conjugates have reshaped the treatment of patients with metastatic breast cancer, especially for HER2 low and ultra low. But before we go on, it's very important to understand that HER2 low does not mean that they are slightly HER2 positive. They are clearly HER2 negative patients. HER2 blockade has no role in their treatment at any time point. However, their tumor cells have enough surface expression of HER2 to bind a HER2-directed antibody drug conjugate, which basically is chemotherapy delivered to the cells. And when you look at the pie chart of HER2 status in those patients who, by previous criteria, are HER2 negative, only 5.4% are HER2 null. Others are either HER2 low, which is more than 2/3, or ultra low, which is more than a quarter of the patients. So all of these patients now are candidates for T-DXd, as I'll show you. First trial was DESTINY-Breast04, which looked at the standard dose of T-DXd versus treatment of physician's choice, capecitabine, eribulin, gemcitabine, paclitaxel, or nab-paclitaxel. All they needed to have was HER2 low, unresectable advanced breast cancer treated with 1 to 2 prior lines of therapy. And hormone receptor positive patients had to be endocrine refractory. And on the right-hand side, you see the structure of the drug. It has 3 parts. It has trastuzumab antibody as a target-seeking device attached with a stable linker to the payload, which is deruxtecan, very similar to irinotecan. It's a topoisomerase 1 inhibitor payload. And his chemotherapy was 5 months longer and highly statistically significant, and median PFS by blinded independent review in the intent to treat population, similar gap, and at the bottom, ultra low population, same gap of 5 months. Now, when you look at anti-tumor activity in terms of response rate, CR, PR, and clinical benefit rate, you can see that responses were really seen in a large percentage, with clinical benefit being seen in 3/4 of the patients with TDXD and a little over half the patients with chemotherapy. Now, these are treatment emergent adverse events. And as you can see, nothing is surprising here because now we are familiar with this drug. ILD pneumonitis, which is of special interest, you can see that grade 3/4 was only 0.7 as shown here, and 0 with chemotherapy. So TROPiCS-2 shows the other ADC, sacituzumab govitecan, which is a TROP2 antibody. TROP2 is expressed in 80+% of breast cancer patients' tumors, so it's not even required to test for it. And the treatment of physician's choice here was capecitabine, vinorelbine, gemcitabine, or eribulin. These patients had to have endocrine therapy and a taxane and a CDK4/6 in any setting, and similar design of the antibody on the right-hand side. And you see similar separation of curves, 4 months in treatment of physician's choice versus 5.5 months. So the gap delta was smaller in this trial compared to what I've just shown you for TDXD. And overall survival shown here, which is, again, not really a 5-year follow-up, but you can see that this p-value was significant for a 3-month survival advantage. Can we give ADC after an ADC? Well, that is not very clear because of retrospective nature of these studies. But the answer is, first, PFS is always longer than the second PFS, no matter which ADC is given after the other ADC. Finally, at this year's ESMO, in an educational session, there was a European algorithm. I've shown you NCCN guidelines in the beginning. For fair balance, I'll show you that in Europe, after first-line CDK4/6 AI and progression, they also recommend somatic mutation testing for germline BRCA, PALB2, in addition to other mutations. If there are no mutations found, then fulvestrant plus everolimus or fulvestrant can be given for ESR1, elacestrant for PIK3CA. You have 2 options of fulvestrant alpelisib. But if there are other mutations like AKT1 or PTEN, for that only capivasertib is approved for germline BRCA, PALB2, PARP inhibitor. When patient progresses through all of that, and there's no further endocrine therapy to offer or targeted therapy to give, then you would, of course, go to cytotoxic chemotherapy. And now the antibodies have made this very murky because I just showed you that now DESTINY-Breast06 even ventured into the first-line space. So in summary, treatment options for hormone receptor positive, HER2 negative patients have expanded significantly with the introduction of targeted therapy and ADC, while a cure remains elusive. Determining the right sequence beyond first line has become a challenge. Quality of life and cost considerations remain important, and role of immunotherapy in this subpopulation is being explored. Thank you very much for your attention.
Thank you so much, Professor Jandev. Now, I would invite Dr. Naila Zahid to come on the stage. And we have Professor Jandev and Abdullah Al-Hasso online. So if you have any question, please, feel free to ask. Yeah. Dr. Jandev, are you online? Oh, so
Yes, I'm here.
Thank you. So I have a question for you. How we saw the result of Patricia on C and Monarch Her trial. So although these both were phase 2 trial and they were very small trial, so how comfortable you would be to bring the combination of CDK4/6 inhibitor with anti-HER2 in your clinical practice?
Well, I'm comfortable, but this should have been for Dr. Shahina Daud. Is she not with us?
Okay. So, and one more question. So, as you mentioned regarding the chemotherapy in the as a hormone treatment combination with CDK4/6 inhibitor in the patient who are in visceral crisis. So, what percentage of hormone positivity would you consider safe for the in the right choice trial? As you know, the majority of the patient, more than I think majority of the patient were having 50% above ER positivity. So what do you consider that those patients could be considered for combination of hormone and CDK4/6 inhibitor?
Okay, that's a great question. ASCO-CAP guidelines changed in 2007, where prior to that, you needed to be 10% positive to be considered ER/PR positive, but they changed it to 1%. That was because hormonal therapies are so well tolerated that everybody should be given the benefit of the doubt. But practically, when we studied and followed data, patients who are less than 10% positive behave just like triple negative patients. So in the recent clinical trials, the cutoff that has been used is 10%. So anybody below 10%, I would not consider ER positive or PR positive. And then there are these patients who are ER negative and slightly PR positive. Those patients also should be considered triple negative. The main thing is when you think that somebody is so rapidly progressive and such large tumor burden, especially a young patient, somebody who arrives on an oxygen tank and on a stretcher, those patients, maybe you should use chemotherapy, but in most other situations, I would try to do CDK4/6 plus hormonal blockade, whether it's with AI or fulvestrant.
Thank you. So one more question, Dr. Abdullah. So AMRAS trial. So I think this is the most common trial which we practice in the UK. So you know that only around 5% of the patient were having 3 positive sentinel lymph node biopsy positivity. So how comfortable you would be in the patient who have 3 positive breast cancer to consider them for the axillary radiation?
Yeah, okay, thank you very much. I think obviously things have moved on quite a lot since the Amaros trial. And I suppose in principle, these patients, at the moment when you do sentinel node biopsy in the sort of post-operative setting, not neoadjuvant setting, we generally get sort of 2 nodes in the majority of cases, and really the number of nodes is not crucial in terms of determining the need for nodal irradiation. So in other words, even if there is 1 or 2 nodes, and there may be more further higher up in the axilla, in that setting, we will be comfortable to offer these patients regional nodal irradiation. But obviously, you have to take into consideration additional factors, for example, grade, receptor status, overall primary tumor site, and so on. So in principle, it's actually the nodal number of nodes doesn't really matter very much anymore, whether this is in fact applying for systemic treatment or indeed for regional nodal irradiation.
Thank you so much. So due to the time issue, we will just wind up the session. Thank you so much, everyone, for joining us. Thank you.
Thank you so much, Bob. Thanks for having me.